Greetings. So let's take further look at transplant and transplant medicine and transfusion medicine. Um, and let's begin with start two of this. So let's talk about some terms in transplant. Again, should be a review from the previous video. So you have the graft, which is the transplanted tissue. You have the donor, the one that donates the graft, and then the host, that is the recipient of the graft. Okay? So those are some basic terms. Now, the transplants are of different types. So let's take a look at that. There's 4 types. See, you'll make it easy. There's auto, iso, allo, and xeno. Didn't spell it correctly. Xeno. So auto is self. Iso is not self, but it's a monozygotic twin that is the donor and you're the host. So auto is where self is the donor and self is the host. So you donate to yourself. For example, in coronary artery bypass graft, they take the saphenous vein and bypass the coronary blood vessels. So again, you are donating tissue to yourself just from one part of the body to another. So there's no rejection there because it's your body. Isograft is donor is monozygotic twin. So in other words, genetically it's identical to you because it's monozygotic. It comes from the same zygote. However, again, when one matures or grows, the immune system matures differently. So the immune system does have some variation, but in general, there's lesser likelihood of rejection. And that's called isograft. There's a third one, which is allograft, and that's same species. So in other words, kidney from a non-monozygotic twin. So there's a human donor, but not a monozygotic twin, and another human gets it. So that's allograft, and that's the most common type of transplant. Xenograft is where the donor is a different species. And before you recoil in horror, pocrine heart valve or pig heart valve is one of the ones that sometimes that transplant or that graft is used in patients. So that's 4 types of transplants. Okay. Now, just a very brief introduction. So how are the transplanted organs distributed amongst people that need it? Because at one time there's several people that may need a kidney. So who gets it? So again, the supply of transplant of graft organs or organs that are donated is not too much. Except kidneys and bone marrows, a lot of organs they come from people after death. So again, it's the supply is lower, demand is higher. So the way to distribute it, everybody who needs a transplant is put on a registry. Okay, the registry. So these are patient 1 that needs it, patient 2 that needs it, patient 3 that needs it, patient 4 that needs it. So whenever an organ becomes available, okay, that organ is matched. So for example, let's say kidneys become available, or let's say the heart becomes available. So what we do is we find who the sickest person is and who the closest match is. So the sickest person who is the closest match actually gets the organ. This way, they get the best chance in life. They need that organ the most, and that organ is a closest match to them. So that organ will have a higher likelihood of doing them good. So they need most help, and they can get most help by these principles. So That's just some principles on how these organs are distributed. Okay. Now let's take a look at the next thing here, which is the I call it one of the higher yield content areas, which is transplant rejection. So remember we talked about how you can transplant the organ and it can be successful or it can be not successful. Well, when it's not successful, it's when the organ is rejected. And so that's called transplant rejection. And in real life, and also on your test, to determine, you may be asked to see if you recognize what kind of rejection it is and what is the general plan for that rejection. Okay, how do you fix it? So do you recognize what kind of rejection symptoms the patient is having and how can we fix it? So the goal is, how would you recognize it as to which kind of rejection it is? So here's the decision tree for it. So step one, take a look at what the symptoms are. Okay. Um, and the symptoms can be broken down into two different parts. So the first symptom is the most common that you would encounter, and that's host versus graft disease. What does that mean? Remember that person that got that donor tissue? So the person that got the donor tissue is the host, and the transplanted donated tissue is the graft. So here the host attacks the graft. That's why it's host v graft, or HVD. So when the host attacks and kills the graft, this is again most common. And what is going to be the symptom? The transplanted tissue is going to fail. So if I give you kidneys and they have host versus graft disease, the host is going to kill the graft. Their pancreatinine is going to go up. Their urine output is going to go down. Kidneys are not going to function. If I give you heart, they're now going to have symptoms of heart failure. If I give you liver, you're going to have symptoms of liver failure. If I give you lungs, they're going to have lung failure. Fair? Okay. The second one is graft versus host disease. Well, wait, what does that mean? Again, we go draw the same things. Remember, this was the host that got the graft. Okay? In this uncommon reaction, what happens is the graft actually attacks the host. So the graft attacks the host. So it's graft versus host disease. Okay. What symptoms would you have? Skin, painful rash. Liver failure with increased liver enzymes. Okay. And jaundice. And gastrointestinal symptoms. So GI pain, especially distal GI pain, bleeding, and diarrhea. Okay. You with me on this? So step one, ask yourself, is the question or the patient telling me, do they have symptoms of host versus graft disease? In other words, are their organs failing? Or do they have symptoms of graft versus host disease, which is skin, liver, and GI symptoms that I just went through? Okay. Step two, ask them the timeline. From how long from when they were transplanted did these symptoms develop? If you can answer these two questions, you will know what kind of transplant rejection they're having. So let's look at it. Step one, you're given symptoms. If you're given host versus graft disease symptoms, then you got host versus graft disease. If you're given symptoms of graft versus host disease, then you got graft versus host disease. Now, with graft versus host disease, if the graft versus host disease is less than 3 months from the transplant, it's acute graft versus host disease. If it's greater than 3 months, it's chronic graft versus host disease. Graft versus host disease can happen anytime after transplant. Again, treatment is high dose corticosteroids. And the transplant team has to manage this. The second one is host versus graft disease, right? That was the first one we talked about, the one where the organ is failing and the host is attacking the graft. Here, take a look at the timeline. Remember the second step of what's the timeline? And the best way to learn this is 2 minutes, 2 weeks, and 2 months. If your organ fails immediately or within 2 minutes, it's hyperacute. Same symptoms, hyperacute. Just 2 minutes. Same symptoms, but it happens between 2 weeks to 2 months. It's acute. If it's greater than 2 months, it's chronic. So in other words, if you are given a question and you have to guess, and you're asked to determine the best what's going on, first step is to determine what symptoms are you given. If it's graft versus host disease or if it's host versus graft disease. So if it's host versus graft disease, the symptoms are exactly the same. They're going to be symptoms of the organ failure. If it happens within 2 minutes, it's hyperacute rejection. If it happens 2 weeks to 2 months, it's acute rejection. If it's greater than 2 months after the transplant, it's chronic rejection. If it's graft versus host disease, you're going to have the same symptoms. What are the symptoms? You got it. Liver symptoms, skin rash, and GI symptoms. If it happens 3 months, within 3 months of the transplant, it's acute. Greater than 3 months, it's chronic. Okay? So now that you have 3 kinds of host versus graft disease, one is hyperacute within 2 minutes. Way to remember it is hyper children eat tic tac. I've again found this online. This is not me. Okay. Hyperacute rejection is type 2, tic tac. Essentially, the blood vessels they clot or they thrombose. It's type 2 hypersensitivity. Removal of graft is the treatment. It's sad and it's necessary to remove the graft. Okay. Now, what if, again, you have the same symptoms of organ failure and this has happened 2 weeks to 2 months after the transplant? Now you got acute rejection. Acute rejection. And the way to remember this is weak rotting teeth require meds. Weeks rotting, it's vasculitis. Teeth, it's type 4 or cell-mediated hypersensitivity, and it requires medication. So it requires increased immunosuppressive medication. It's a type 4 hypersensitivity which leads to vasculitis, and that can be treated with the increased immunosuppressive medication. Okay. Excellent. The third one is chronic. What are the symptoms? Same symptoms. Organ failure. It's host versus graft disease. This would be type 2 and type 4 both. Leads to fibrosis and essentially the graft is no good. And again, the hope is to retransplant. The plan is to retransplant and look at doing the transplant again with a different organ. Okay. So let's take a look at how, now that we understand rejection, how it sort of works. So this is a graph where the function of the transplanted organ is here. This is the time where the transplant happens, okay? And this is kind of the patient's life or time. So usually what happens is if I match all of the if I match all of the, so let's say we're doing a solid organ transplant or bone marrow, and we match all the six MHC1 and MHC2 HLA antigens, then usually they they retain most of the function over time. If, however, I have less number of matching that happens, again, the immune system of the host attacks. And so you see the organ function goes down much more dramatically, and they have the time that the organ provides function, the transplanted organ provides function, is way less. Okay. So again, we want to match all of them or as many as we can so that we can get most time. So what usually happens is they get transplanted, and again you can have hyperacute rejection, which means the organ needs to be taken out. And then let's say they don't get rejected and they don't get hyperacute rejection. Over time, you're going to have periods of rejection. And again, the curve is going to take a dip. And the hope is if we can manage this dip, identify that they're undergoing a period of rejection, remove the stressor, maybe manage the transplant if we need to increase the immunosuppression or alter the immune system or decrease the immunity or immune response by increasing the immunosuppression or immune suppressive medication. We do it, the curve comes back. And this is how it rolls. You have periods of stress, they get managed. Periods of stress, they get managed. If we don't manage them, then they go take a different curve, and they have lesser likelihood of a higher life with that organ and that transplanted organ having a good function. Okay, so it is sort of the duration of management is the duration of how the transplanted organ is in the system. And so it may at times be lifelong or maybe the life of the patient in several cases. Okay, so that's the course of the transplanted patient. So medications that are used to suppress the immune system, again, review pharmacology. The big ones are glucocorticoids, and with DMARDs, there's cyclosporin, tacrolimus, sirolimus, and there's some monoclonal antibodies as well that are used, and azathioprine, and so these are some of the medications that are used to suppress the immune system, especially when it comes to transplant. So let's talk a little bit about the nursing intervention. So pre-transplant, what is the biggest thing? Look, the organ is failing. How can I manage and optimize the failing organ? Because that will give me most time to get a transplanted organ. So I preserve the function as much as possible. I put the patients on the registry. Then I get them involved in the antigen testing and matching. And then again, having the transplant team involved. So that's generally what we're doing pre-transplant. It may be that we may need to preserve function as long as possible. So if the kidneys have actually failed, we may need to put them on dialysis. Or if the heart has actually failed and they don't have a transplant organ available, then we put them on ventricular assist devices. And then again, once they are transplanted, then the big question is to monitor the transplant organ function. And that's organ specific. We look for rejection, and it's graft versus host disease and host versus graft disease. And we talked about management for different types of host versus graft disease and also graft versus host disease. and then we coordinate care to maximize the functions of the transplanted organ. And again, that's got to do with that curve we talked about, right? So we want to manage the dips, and we want to make sure the transplant team is involved so that we can get the transplant organ um, its function to be as preserved as possible for as long as possible, which would give the patient the best chance in life. Now, if we are giving some kind of immunosuppression, remember we do need to give them, for the most part, some or the other kind of immune suppression to decrease that residual immune response even after matching. So that immune suppression can give you two big things. So remember when we talked about immunosuppressive drugs, immune system fights infections and also takes out malignant cells. If you suppress the immune system, you're increasing likelihood of both. So to monitor the patient for infection. So again, if these people get a fever, the patient who's undergone transplant and is on immune suppression gets a fever, they get very aggressive therapy. They may get hospitalized. They may get IV antibiotics, while another person who's not on an immunosuppression may be told to go home and take some Tylenol and ibuprofen and fight it out. We have to be very careful about giving them vaccination, and we have to make sure they're vaccinated up to date so that there's low likelihood of any infection happening. And again, malignancy, lots of education about malignancy and making sure we are always keeping an eye to see if they have any and referring if needed. Okay, so again, let's do a quick recap. So in this video, we talked about the graft, donor, and host, and the definition. We talked about the types, so auto, iso, allo, and xenograft. And we talked about general principles of how the transplanted tissue is, given to who is it given to from a set of people that need them from. And we talked about the registry. Then we talked about transplant rejection, and again, your questions may ask you about what kind of rejection, and again, determining what kind of rejection tells you what's the management. So 2 steps: is this host versus graft disease or graft versus host disease? So if host is fighting the graft, then the organ is going to be failing. If the graft is fighting the host, again, that usually happens a lot with bone marrow and stem cell transplants. So it's going to have painful rash, liver jaundice, and liver enzymes going high, and gastrointestinal symptoms like GI, distal GI pain and diarrhea and bleeding. And so that's step one. That will tell you whether it's host versus graft disease or graft versus host disease. If host versus graft disease symptoms are there, 2 minutes, this is hyperacute. Hyper, children eat tic tac. It's type 2 hypersensitivity, which is caused by venous thrombosis. Sad situation, but you gotta take out the transplant tissue. It failed. Uh, if it's 2 months, 2 weeks to 2 months, it's acute, and the organ has failed, and it's acute failure. And that is got to do with weak rotting teeth require meds. So it happens in weeks. Rotting, it's caused by vasculitis because of type 4 hypersensitivity, and they require increase in immunosuppressants. And then the chronic is a combination of type 2 and type 4, which is causing fibrosis. And again, the transplanted tissue is scarred, so we need to consider retransplantation. Um, as far as graft versus host disease is concerned, again, less than 3 months is acute, greater than 3 months is chronic. You treat it with corticosteroids, um, and um, and then we look very quickly at how these patients, once they're transplanted, how do their rest of the life looks like from a transplantation perspective. Then we talked about nursing management and what to do pre-transplant, post-transplant, and how to monitor for complications.